A very good afternoon and welcome to our session on the topic recurrent pregnancy loss. We are glad to have our Dr. Sangeetha Anand who will talk about the topic briefly. Considering the importance of the topic, we would like to hear the doctor with our minute details she'll be sharing with us today. Just in case you have any doubts, any queries, you can put that on the comment section below. The doctor is here to help you. Doctor, you have the stage.
Good afternoon, everyone. This is Dr. Sangeetha Anand, consultant reproductive medicine at Apollo Fertility, Brookfield, Bangalore. Today, I would like to talk about recurrent pregnancy loss. Pregnancy loss is very much devastating for the couple as well as for the doctor. Why does sporadic pregnancy loss happen? 50% of first trimester pregnancy. First trimester in the sense pregnancy loss within first 3 months of pregnancy are mostly due to aneuploid embryos, abnormal set of chromosomes in the embryos which doesn't grow further. Nature doesn't allow an abnormal embryo to grow further. So when you divide a pregnancy loss, we just see the tip of the iceberg. A lot of pregnancies are lost even before the patient realizes that she is pregnant. Right from the step of fertilization, there can be some loss. Just immediately after fertilization, called post fertilization failure, there can be 30% loss. And pre implantation. Before implantation, there can be losses, and then the pregnancy loss. Preclinical and clinical pregnancy. Clinical is what we get to know after the urine test comes positive. Preclinical, or it can be a biochemical pregnancy where the beta HCG might show a just minimal rise in the value and then it might decline. So 30% pregnancy loss happen even in a natural conception. So going by the incidence of pregnancy losses, we divide the whole pregnancy period into 3 trimesters. The first 3 months up to 12 weeks is the first trimester. Most of the pregnancy loss happens in the first 3 months. So 15% pregnancy loss happens in the first 3 months of pregnancy. And only 2% pregnancy is lost in the second trimester, that between fourth, fifth, and sixth month. And again, in the third trimester, the pregnancy loss is very minimal and the stillbirth are very minimal. So, 3 times to 4 times pregnancy loss is common in the first 3 months of pregnancy. Now, how do we define recurrent, which couple you call as recurrent pregnancy loss? Initially, RCOG gave a definition telling that 3 or more pregnancy losses as recurrent pregnancy loss. But the recent ASRM guideline says that even the loss of 2 or more pregnancies as recurrent pregnancy loss. So, what are the etiology? The most common causes we need to analyze. First is the age of the women. Second, chromosomal abnormalities. Next, any immunological causes or thrombophilia related causes or any defects in the uterine cavity. By birth, there can be anatomical defects in the uterine cavity or any chronic infections inside the uterine cavity. Same, male can also contribute to recurrent pregnancy loss when there is a high DNA damage happening to the sperms, which can lead on to first trimester pregnancy loss. And we are able to find the reason only in 50 to 60% of the causes, and the remaining 40 to 50% it's idiopathic. That means without any reason there can be a pregnancy loss. So now going, if there is a pregnancy loss, the couple should not lose heart. The prognosis after a single pregnancy loss, after a single sporadic miscarriage, the chances of having a live birth, healthy pregnancy is up to 80%. So with one miscarriage, couple should not lose their hope. 80% there are chances that they can achieve a healthy pregnancy second time. So after 2 miscarriage also, there is about 70% chance to have a healthy pregnancy. After 3 miscarriage also, there can be 60% live birth with treatment. So, and as I said, the reason for the pregnancy loss can be found only in 50 to 60% of the cases. Next is advanced age. Advanced maternal age. The woman's age is associated with a risk of having abnormal set of chromosomes in the eggs as well as the quality of the eggs. So this advanced mother's age is a most common risk factor for miscarriage. Second, advanced father's age. Paternal age also has been identified as a risk factor for miscarriage. So the risk of miscarriage is highest among couples where the woman's age is more than 35 years of age and the man's age is more than 40 years of age. As I said, age plays a very important role. So, as I said, the chromosomal abnormality plays a very important role in miscarriage. So, what type of chromosomal abnormality? Numerical chromosomal abnormality. As we all know that a single cell has 23 pairs of chromosomes, 22 pairs of autosomes and one pair of sex chromosome. Any alteration in the numerical numbers of this chromosome can lead to abnormalities. As I said, 50 percentage of first trimester miscarriage are because of these chromosomal abnormalities. These chromosomal abnormalities can contribute to 15 percentage of miscarriage in the second trimester. That is, even in the second trimester, there can be pregnancy loss because of these chromosomal abnormalities. And very rarely we do see third trimester pregnancy loss or stillbirth because of the chromosomal abnormalities. And 0.6 to 8 percentage, 0.6 to 0.8 percentage of live birth can happen even with a chromosomal abnormality. So, what are the type of chromosomal abnormality? Numerical means most common what we all know is Down syndrome and Turner syndrome. Trisomy is the most common, which contributes to 30 percentage of the chromosomal abnormalities. Next, like triploidy, tetraploidy, they all contribute 10 percentage, 5 percentage. And Turner syndrome, like where there is 45 X0 chromosome, contributes to 10 percentage. Others remaining contribute to 50 to 55%. So the embryonic chromosomal abnormalities is very high among women with recurrent miscarriage. In couples with recurrent miscarriage, the chromosomal abnormalities account for about 30 to 50 percentage of the miscarriage. As the number of miscarriage increases, if the miscarriage is because of these chromosomal abnormality and if the number of miscarriages increases, the chance of having a euploid pregnancy reduces in these set of couples. So, parental chromosomal rearrangement are very important. In approximately 2 to 5 percentage of the couple with recurrent miscarriage, the one of the partner might be having a structural chromosomal abnormality. It can be a balanced translocation or it can be a Robertsonian translocation. So, carriers of this translocation are physically might look normal, but their pregnancies are at risk of a miscarriage and may result in a live birth with an unbalanced translocation, or it can lead to a miscarriage. The risk of miscarriage is influenced by the what set of genetic material is transmitted to the embryo or what kind of rearrangement has happened to the chromosomal segment. Next, going to the other cause for miscarriage. Next is called the antiphospholipid antibody syndrome. This is the most common, more important, and easily treatable cause for recurrent miscarriage. So, antiphospholipid antibodies are present in 15 percentage of women with recurrent miscarriage, and they are even seen in 2 percentage of the general population. They are more common among women who have repeated miscarriage. In women with recurrent miscarriage that is associated with antiphospholipid antibody syndrome, if they are not treated in first trimester of pregnancy, as soon as the pregnancy is confirmed, the chance of having a live birth is only about 10%. How does this antiphospholipid antibody syndrome cause miscarriage? It can inhibit trophoblast invasion. Trophoblast function can be affected. It can activate the complement pathway on the maternal fetal interface, reducing the inflammatory response, increasing the inflammatory response. In later part of pregnancy, it can cause thrombosis of the vasculature, reducing the uteroplacental perfusion, reducing the blood flow to the baby. So it can affect the blood flow to the baby. So how can it can cause miscarriage? One is by affecting the trophoblast function, affecting the trophoblast invasion. Second, it can activate the complement pathway, resulting in an inflammatory response. Second, it can cause thrombosis of the blood vessels, affecting the blood flow to the baby. How do we diagnose this antiphospholipid antibody syndrome? These tests are done when there is a history of at least two first trimester miscarriages. So there are some clinical criteria plus some laboratory criteria to diagnose a patient as having Apla syndrome. So what are the clinical criteria? One, when there is a history of vascular thrombosis. Thrombosis means blood clot in the blood vessel. Second, when there is a pregnancy morbidity. Pregnancy morbidity means pregnancy loss. When there is one or more unexplained death of a fetus, which is phenotypically looking normal below the 10th week of pregnancy, which is detected by ultrasound, or when there is a loss of pregnancy in the second or the third trimester because of severe preeclampsia or eclampsia, when there is a high blood pressure and morphologically normal looking fetus is lost in the second or the third trimester, or if there is a loss of two or three first trimester pregnancy loss in a in a set of embryos where the chromosomal abnormalities have been ruled out. These are the clinical criteria. Going to the laboratory criteria, what are the blood tests we do to diagnose antiphospholipid antibody syndrome? Three markers are there. One is lupus anticoagulant. Second is anticardiolipin antibodies, which are detected IgG or IgM. They should be present in moderate or high values, and they should be detected twice at an interval of 6 to 12 weeks. Next is beta 2 glycoprotein. Again, they're measured in titers of IgG or IgM. Titers should be moderate or high values, and they should be detected on two occasions, 6 to 12 weeks apart. So these are the laboratory criteria. Few are clinical criteria and few are laboratory criteria to diagnose antiphospholipid antibody syndrome. Other than these, other endocrine disorders like diabetes or thyroid dysfunction or autoimmune thyroid antibodies, all that play a role in causing recurrent pregnancy loss. Systemic maternal endocrine disorders, diabetes and thyroid dysfunction should also be excluded in the investigation for recurrent pregnancy loss. But women with diabetes with high HbA1c levels are at high risk of miscarriage. Second, polycystic ovarian syndrome. PCO women are also at high risk of miscarriage. Next, however, when the diabetes is under control or the thyroid dysfunction is properly medicated, then the risk of miscarriage is less. High or low prolactin again is associated with an increased risk of miscarriage in a subsequent pregnancy in women with unexplained recurrent pregnancy loss. Vitamin D deficiency has been shown to be associated with several obstetric and fetal complications, but there is no solid evidence to tell that vitamin D deficiency is an isolated reason for miscarriage. Next, going to the anatomical defects in the uterine cavities. When there is a congenital uterine abnormality, uterine cavity has a septum or a bicornate uterus or a fibroid, submucous fibroid, or a cervical incompetence or intrauterine synechiae or adhesion, scar tissue inside the uterine cavity where the embryo is implanted on the septum or the synechiae can lead to recurrent miscarriage. Like uterine anomalies. When you look at the congenital uterine anomalies, uterus develop from Mullerian duct. So when there is a defect in the fusion of the Mullerian duct, there can be congenital uterine anomalies. They are present in about 4% to 5% in the general population. And when you look at the infertile population or the people with recurrent pregnancy loss, it can be as high as 12 to 15%. What type of congenital uterine anomalies are associated with miscarriage and which has got the highest chance of miscarriage? Most of the times, we see that septate uterus, around 40% can have a miscarriage, that too in the second trimester. Bicornate uterus can also have a risk of miscarriage, but it's around 30%. Arcuate uterus are mild form of uterine anomalies, which are not very specific or very high risk of miscarriage. It can even result in a miscarriage in about 20% of the cases. These anomalies are usually detected by, usually we do a 3D ultrasound, which is the diagnostic test. Hysterosalpingography or a saline salpingography can also detect these kind of uterine anomalies. A septate uterus, when the septal resection is done, it increases the chance of pregnancy and reduces the risk of miscarriage. Septate uterus is the most common uterine anomaly that is associated with recurrent pregnancy loss. Septate means there will be a normal uterine cavity and there will be a division in between. That division might not have a proper blood flow like the normal uterine musculature. So when the embryo attaches to this lining, it might not have a proper blood flow, which can lead on to first or most commonly the septate uterus leads to second trimester miscarriage. Correction of these septal defects, in particular in women with recurrent pregnancy loss, has been found to be beneficial. It has been found to give healthy live pregnancies in around 80% of the patients and should be considered in a patient with recurrent pregnancy loss. But there are disadvantages which can lead on to adhesions and scar tissue, which has to be properly taken care of. Other uterine anomalies, other anatomical abnormalities, as I said, submucous fibroid, which is inside the uterine cavity. If the embryo implants on the submucous fibroid, it can lead to miscarriage. Other than that, there can be Asherman syndrome. Asherman means because of recurrent miscarriage or a D&C, there can be intrauterine synecdoche, which has less blood flow, which the scar tissue, the fibrous tissue has less blood flow, which can lead on to miscarriage. Uterine polyps, because all these are still controversial, but there is a definite association with recurrent pregnancy loss. There are randomized trials in this area, are not much there, they are lacking, so that it is very difficult to um, give a general opinion on what to do for a mild septate uterus. Next, cervical incompetence. Clinical diagnosis is important. Cervical weakness is a recognized cause of second trimester miscarriage. But when the patient gives a previous history of a second trimester miscarriage, then cervical incompetence should be suspected. These patients can have a prophylactic cerclage. The diagnosis is usually based on the history of a previous second trimester loss and proceeded by a spontaneous rupture of membranes, spontaneous labor pain. So this is a clinical thing which the clinician should correlate with the previous history and the clinical findings plus the cervical length. This is one common cause for second trimester pregnancy loss, especially in patients with a history of surgery on the cervix or a history of uterine anomalies diagnosed before pregnancy. They should be very careful in looking at the cervical length from the first trimester of pregnancy. Next, going to the inherited thrombophilias. As I said, any inherited thrombophilias where there is a risk of blood clotting happening in the vasculature, where there is a blood flow from the mother to the baby through small blood vessels. When there is a risk of thrombosis or blood clot in these blood vessels, it can lead on to miscarriage. Most common factor V Leiden mutation, prothrombin gene mutation, some deficiency of proteins, protein C, protein S, antithrombin 3 deficiency. All these are associated with recurrent pregnancy loss. A positive test result is not associated with improved outcome, but for the couples, based on the lack of effect of treatment on pregnancy outcome. Other than these thrombophilias, some environmental exposure to chemicals, lead, arsenic, heavy metals, all these are also been associated with a risk of miscarriage. Plus, when you look at the male, you have to look at their personal habit, obesity, smoking, alcohol, excessive caffeine consumption on the paternal side also can be a reason for miscarriage. Couples with recurrent pregnancy loss should be informed about the prognosis of live birth even after three pregnancy loss. As I said, even after three pregnancy loss, there is a 60% chance to have a healthy pregnancy. So, couples with RPL should be informed that excessive alcohol consumption, smoking, obesity, all that have been proven to be a risk factor for fetal problems, like there can be fetal alcohol syndrome. They should be advised to avoid alcohol consumption. Couple with RPL should be informed that the maternal obesity, as I said, is significant risk factor overweight and obesity as a risk factor for a live birth, which can lead on to recurrent pregnancy loss as well. So, for a healthy, normal BMI should be the ideal thing for a healthy pregnancy. Stress. Recurrent pregnancy loss itself can lead on to stress, but stress as such can contribute to pregnancy loss. But it cannot be a major factor. But they should be informed, couples should be informed that there is no evidence to tell that there is a direct effect of stress on pregnancy loss, but it can be a contributory factor. Next, going to the infective causes. Any severe infection that leads to bacteremia or viremia can cause chronic endometritis and sporadic miscarriage. For an infective agent to be implicated as the sole etiology of recurrent pregnancy loss, it must be capable of persisting in the genital tract, and we have to detect it by the test, and it must, and most of the time there is insufficient symptoms to conclude that that is the reason for miscarriage. Toxoplasmosis, rubella, cytomegalovirus, herpes, all these infections do not fulfill all these criteria, and routine TOT screening is also not advised for in a case of recurrent pregnancy loss. Only for that particular sporadic pregnancy loss, TORCH infection can be attributed, not in the case of a recurrent pregnancy loss. Next, going to bacterial vaginosis. Presence of bacterial vaginosis in the first trimester of pregnancy has been reported to be a risk factor for second trimester loss, because it as such doesn't cause the pregnancy loss within the first 3 months, but presence of this infection over a long period of time in the fourth, fifth, or the sixth month of pregnancy, it can lead on to chorioamnionitis, it can lead to preterm deliveries, premature rupture of membranes. All these are associated with the second trimester loss. There was a randomized placebo controlled trial which reported that the treatment of bacterial vaginosis early in the second trimester with oral clindamycin, it significantly reduces the incidence of second trimester miscarriage and preterm birth in the general population. Next, going to chronic endometritis. The presence of plasma cell infiltrates into the endometrium that is associated with a range of pathogenic organisms can lead on to recurrent miscarriage. It can also be a reason for recurrent implantation failure. In repeated IVF failures, also chronic endometritis can play a role. The prevalence has been found to be as high as 7 to 10 percentage in the infertile population, as well as in patients with recurrent pregnancy loss. Antibiotics were found to remove this chronic endometritis or to resolve this endometritis with an apparent improvement in the live birth rate. However, that concept has not been tested in large trials. But definitely, treating chronic endometritis plays a role in recurrent pregnancy loss. It does improve the results. Next, women with recurrent pregnancy loss should be looked after by a health professional with the necessary skills, and it needs to be they need to be treated in a high risk clinic. Recurrent pregnancy, miscarriage, there should be separate clinics who look at people with recurrent miscarriage. They should not be checked like just like a natural conception or a first pregnancy. So, what are all the investigations we do? Like as I said, family history and a medical history can be used to diagnose some of the investigations for recurrent pregnancy loss. And age as a factor can give us a clue on the reason for the miscarriage. Lifestyle, as I said, obesity, smoking, alcohol, all these may contribute. Next, the menstrual history, irregular menstrual cycle, which gives an indication for PCOS. Second, severe dysmenorrhea can be associated with endometriosis or adenomyosis, which is again a risk factor for pregnancy loss. Next is like any endocrinopathy, irregular cycles, high prolactin, high thyroid levels, which can cause irregular cycles, again can be associated with recurrent pregnancy loss. Next is the gestational age at which the miscarriage happened. As I said, the chromosomal abnormalities are more common in the first 3 months of pregnancy. So, second trimester miscarriage, again, you have to look at uterine anomaly, cervical incompetence. Even then, we cannot exclude chromosomal abnormalities in the second trimester. Next is the embryonic cardiac activity, whether the cardiac activity was present and then it disappeared. So chromosomal abnormalities more common if miscarriage occur prior to the detection of chromosomal abnormalities. Nature doesn't allow an abnormal embryo to grow beyond a stage. So the cardiac activity appears like one first milestone. So if that doesn't happen, we suspect chromosomal abnormality. Next, going to the medical history. As I said, history of diabetes, thyroid dysfunction, high prolactin, irregular cycles, or a family history or a personal history of blood vessel thrombosis, venous or arterial thrombosis, which again gives us a suspicion of APLA condition or any inherited thrombophilias. Any surgical history, like if you have a history of surgery on the cervix, which can be a risk factor for cervical incompetence, or a DNC, where there is a risk of intrauterine scar tissue called Asherman syndrome. All this can contribute so that you get a suspicion that this could be the reason for the miscarriage. Looking at the patient and asking few questions, asking the family history, personal history, previous medical history, previous surgery history, all that gives us a rough idea of which way to go about in treating a patient with RPL. And then comes the present investigation. As I said, first we need to look at how many miscarriages have happened, then rule out chromosomal abnormalities, then do the thrombophilia, APLA, thrombophilia, SLE screening, inherited thrombophilia, look at uterine anomalies, any endocrine abnormalities, and even if everything is normal, as I said, 60 percentage they might be idiopathic. So, how to go about with checking for a chromosomal abnormalities in the embryo? In the first miscarriage, no action needs to be taken unless clinically indicated. If there is a second miscarriage, the products have to be sent for chromosomal microarray. If it comes out aneuploid products of conception, then no further evaluation is required. But if there is an unbalanced or a translocation or an inversion, then it's better to perform the parental karyotype. When there is an unbalanced chromosomal translocation, you expect a balanced chromosomal translocation or a Robertsonian translocation in the parents. So you perform a parental karyotyping. And if you find any abnormalities, send them for genetic counseling. If there is an euploid, normal chromosomal content in the products of conception, then you go ahead because the chromosomal abnormalities are ruled out. Go ahead with other investigations for RPL. As I said, APLA, SLE, thrombophilia, all these investigations goes. So how you go about with the chromosomal abnormality? First pregnancy loss, don't do anything. If there is a second loss in the first 3 months, the products of conception shows, send it for chromosomal microarray. If they are aneuploid, then no further investigation. If it shows an unbalanced chromosomal translocation or an inversion, then we need to check at the parents to look for any balanced chromosomal translocation or a Robertsonian translocation. Or if they are euploid set of chromosomes, euploid means normal set of chromosomes in the products of conception, then we need to do the other thrombophilia, other investigations for recurrent pregnancy loss. Other thing means, as I said, APLA, SLE, thrombophilia, anatomical defects, uterine anomalies, as I said, by 3D ultrasound or hysterosalpingography or saline salpingography. And if you find a major anomaly, as I said, like a septate uterus, then you can go and do a septal resection. All women with recurrent pregnancy loss and all women with one or more second trimester pregnancy loss should be screened for antiphospholipid antibody syndrome. Uterine assessment by 3D ultrasound. So all women with pregnancy loss should have an assessment of the uterine cavity. Usually, the very simple technique, preferred technique is 3D ultrasound. Saline sonosalpingography, where we push saline from down and then it fills up the cavity. You can look at uterine anomalies, endometrial polyps, submucous fibroids, all that are clearly seen with saline sonography. If a Mullerian uterine malformation is diagnosed, further investigation should be considered. As I said, in the male partner, we have to assess the lifestyle factors like history of smoking, alcohol consumption, and then exercise pattern and body weight. Assessing the sperm DNA fragmentation in couple with recurrent pregnancy loss can be considered for explanatory purpose, and they have given good results as well. If the DFI is high, put the husband on antioxidant. Tell them, explain them about healthy lifestyle. If the husband is obese, ask him to lose weight. If he has a habit of smoking, ask him to quit smoking. All this has an impact on live birth. So DFI, if the high DFI is deducted, then that can also contribute to pregnancy loss. Some diagnostic tests, although they are not recommended for all couples, can be relevant only in selected patients with recurrent pregnancy loss. As I said, intralipid, intravenous immunoglobulin, all these are practically being used, but there is no strong evidence to tell that there is a direct effect of using these medications. Like prolactin testing in women with clinical symptoms of hyperprolactinemia, and HLA class 2 antigen testing, all these have no solid evidence. So, as I said, even if all the tests are normal in 50 to 60 percentage of the patient, how do we go with the treatment? Even if APLA is negative, but there is a history of repeated miscarriage or a recurrent implantation failure in IVF patient, we give them aspirin, low dose ecosprin, starting from before conception. And once the beta HCG come positive, we start low molecular weight heparin injection. Once the pregnancy test comes positive, and then continue for 3 months of pregnancy. In a patient who is APLA positive, we continue even up to 32 weeks. Antiphospholipid antibody syndrome, pregnant women with this APLA should be considered for treatment with low dose aspirin and heparin once the pregnancy is confirmed. Treatment combination leads to a significant increase in the live birth rate in women with APLA syndrome. Pregnancies that are associated with Apple syndrome can be complicated throughout the 3 trimester of pregnancy. There are the risk of threatened abortion. Then there is a risk of preeclampsia, and they have a risk of fetal growth restriction and preterm birth. But all these have to be seen in a high risk pregnancy clinic. Next, finding a abnormal parental karyotype. So you see a balanced chromosomal translocation, then the patient has to be sent to the genetic specialist who can tell the reproductive outcome in the next pregnancies. They can give us an idea about what is the probability of the same kind of chromosomal abnormality in the further pregnancy, and reproductive outcome can be assessed. These kind of patients, reimplantation genetic testing is a boon for these kind of patients, which can help to detect the chromosomal abnormalities in the embryo even before implantation. Further, they should be informed that there is a high chance of having a healthy live birth after pre-implantation genetic testing. Congenital uterine anomalies, as I said, septate uterus gives a higher live birth after a septal resection. Cervical weakness. If there is a second trimester loss in the previous pregnancy, a prophylactic cervical cerclage helps prevent the pregnancy loss. And unexplained recurrent pregnancy loss. As I said, about 40 to 50 percentage of the cases, we are not able to find the reason for the miscarriage. And for them, treat as though they are APLA positive. Treat as though they have autoimmune condition associated with the pregnancy loss. If there is no reason detected, treat as though they are positive, and it can lead on to a healthy pregnancy in 40 to 50 percentage of the cases. And these kind of patients are under huge stress, so they need psychological support intervention to reduce the level of stress and anxiety or the depression in women going through these kind of miscarriage is very important, because many women with these kind of unexplained recurrent pregnancy loss can have they can go into severe depression. So they need constant counseling and positive thoughts so that they don't lose hope. Most of the time, these kind of unexplained, when everything looks normal in a young patient, when you look at them, there might be a diminished ovarian reserve. They might suffer from a premature ovarian aging, or they might be suffering from an autoimmune condition, autoimmune thyroid antibodies, which can lead to a reduced quality of oocyte and as well as the quantity. Very difficult to diagnose these kind of patients. And as I said, immunological causes. There is no immunological biomarker which can be used for selecting couples with recurrent pregnancy loss for specific treatment. Cytokine testing should not be used in women with recurrent pregnancy loss in routine clinical practice. As we said, there is insufficient evidence to recommend testing for natural killer cells, either from the peripheral blood or from the endometrial tissue. Intralipid infusions. Also, there is no solid evidence to tell that it improves the live birth rate. But in clinical practice, we do use them and we do see good results. An altered microbiota in the endometrium can lead on to an altered immunological response. Chronic endometritis, as I said, could be one reason for recurrent pregnancy loss. But the method to detect is by hysteroscopy or by immunohistochemistry. They are seen in about 7 to 30 percentage of patients with recurrent pregnancy loss. And antibiotics have been found to improve the pregnancy rates in patients with chronic endometritis. So immunological response doesn't favor heparin use. Low molecular weight heparin, as I said, it increases the Th1 and Th17 associated chemokine levels during pregnancy in women with unexplained infertility, and it has been found to have a favorable outcome on the live birth rate. So, as I said, recurrent pregnancy loss is very distressing for the patient as well as to the doctor. But we need to find out if one pregnancy loss happens, give hope to the couple that 80% they can achieve a pregnancy, healthy pregnancy second time. It might be a sporadic loss. Lot of pregnancies are lost even before they are detected by a urine pregnancy test or a beta HCG test. So we see only the tip of the iceberg. So if you detect one pregnancy loss, we need to counsel the patient that don't worry, this might be a sporadic thing. Next time you can have a healthy pregnancy. But if two pregnancy loss happens within the first 3 months of pregnancy, that is within 12 weeks, it is the duty of the clinician to investigate, send the products for karyotyping, and then analyze based on the reports whether to investigate for recurrent pregnancy loss, whether to do the blood test, as I said, or do a karyotype and send for genetic counseling. And we need to, even if it comes positive, we have to tell the couple that there are 70% chance to achieve a healthy pregnancy even after two miscarriage, and it's up to 60% even after three miscarriage. So we need to counsel the patient because they might be under huge stress and they need psychological support and counseling. Thank you. Ma'am, my first IVF positive after 2 weeks, miscarriage, a small blood clot, it affected the embryo. Please answer me. Next, it happens, or I'm very fear. See, blood clot after embryo transfer. See, one miscarriage, you don't have to worry. As I said, most common might be some chromosomal abnormality in the embryo. What was your age when you had this IVF? What was the embryo quality? If it was a good quality and A grade embryo, you don't have to worry. You can go ahead with the next embryo transfer. But if you have a previous history of miscarriage or previous failures in IVF, better to go for investigations for recurrent pregnancy loss, as I mentioned in the session, like APLA, SLE, thrombophilia, inherited thrombophilias, and your ovarian reserve, whether your uterine cavity is normal, why you had such blood clots in the cavity, all that to be investigated. Can I close the session? No more questions? Thank you.